Good evening. My name is Heidi White, and I am the Group Fitness and Wellness Manager at JCC Greater Boston. Special thanks to Beth Israel Deaconess Needham and Beth Israel Deaconess Medical Center for their partnership and for helping to coordinate the Wellness Speaker Series, including tonight's topic on breast cancer screening and genetic testing, what every woman should know with Dr. Nadine Tung. Dr. Tung is a nationally known breast medical oncologist who specializes in both breast cancer treatment and cancer genetics. She is the director of the Cancer Genetics and Prevention Program at Beth Israel Deaconess Medical Center, which she established in 1997 to evaluate patients and families with hereditary cancer syndromes. Dr. Tung earned her undergraduate degree at Princeton University and attended Harvard Medical School. She completed her training in medicine and hematology oncology at Beth Israel Deaconess Medical Center. Her research focuses on hereditary causes of breast cancer and effective strategies for breast cancer prevention and treatment. And with that, I'll turn things over to you, Dr. Tung.
Thanks so much, Heidi. I'm going to share my screen and use some slides as talking points. All right. All right. So as Heidi said, we're going to discuss breast cancer screening and genetic testing, what every woman should know. So I think the first question to start with is probably many women ask the question, am I at increased risk of breast cancer? How do I figure that out? And really the first question that has to be asked before we talk about what a woman's risk actually is to ask whether that woman qualifies to have genetic testing. And that means testing to see if she's inherited an abnormal gene that puts her at risk, increased risk for breast cancer. So just some basic terms so that we're all on the same page and nobody feels scared by the terminology. When you hear the word gene, I think it's important just to think of it as the genetic material that we inherit. These genes are really the instruction for the cells in our body. And two examples of genes are BRCA1 and BRCA2 that I'm sure most of the people listening have heard about. So as I said, we do inherit genes from our mother and our father. For every gene, we get one copy from our mother and one copy from our father. And when we inherit a copy of the gene that is abnormal, we call that a mutation, or we call that a pathogenic variant. And that means that there's been a change in that gene that prevents it from working. And for our purposes tonight, it means that inheriting that abnormal copy places someone at increased risk of getting cancer. And this really highlights the erroneous terminology that many people use. They'll say, oh, do you have the BRCA1 gene, or did you inherit a BRCA1 gene? And we all have BRCA1 genes, one copy from our mother and father. We all have BRCA2 genes. Really what somebody means to ask is, have you inherited a mutation in a BRCA1 gene or an abnormal copy of that gene, either from your mother or your father? So again, just to sort of summarize that, we're going to talk about BRCA1 and 2 first. There are two genes, and what do they do? Why do we have them? Because they repair our cells when the genetic material in our cells becomes damaged. And when these genes, BRCA1 and 2, are working, they prevent the development of cancer, like breast cancer and ovarian cancer. And when they're not working, that's when cancers tend to develop. So just the names themselves to help you remember, BR is for breast, CA is for cancer, and 1 and 2 indicate that these were the first two genes that researchers identified for which inheriting an abnormal copy placed a woman at increased risk of breast cancer. Now, we know that breast cancer is not the only cancer that one is at risk for. There's also, for example, ovarian cancer. These genes could have just as easily been called OVCA1 and OVCA2 if the ovarian cancer researchers found them first, but it was the breast cancer researchers that identified them first. So again, any man or woman who's inherited one of these BRCA mutations, each one of their children has a 50-50 chance of getting the abnormal copy of that BRCA gene. And same thing, let's say this man over here has inherited a BRCA1 mutation. Not only do each of his children have a 50-50 chance, if he has sisters and brothers, his siblings each have a 50-50 chance of having that abnormal BRCA gene. So what are the risks when we talk about somebody who was born, somebody who inherited an abnormal BRCA gene? Well, the risk for breast cancer in women over their lifetime is very high, generally over 60%. And even men, more so with the BRCA2 gene, there is a slight increased risk, but not nearly to the same degree as women. But for BRCA2, some men, the risk can get as high as 7%. So there is a slight risk there. But the other cancer women are really at risk for is ovarian cancer. And for BRCA1, the risk can be almost as high as 50 or 60%. And for BRCA2, still quite high. The average American woman has about a 1 to 2% chance of getting ovarian cancer. And here we're talking about a risk of 50% or 30%. And ovarian cancer is very, very challenging because there is no good screening for it. As we're going to talk about breast cancer screening, for ovarian cancer, there's no mammogram, there's no other screening. So really, the key is to find the women who have an increased risk and when they've completed childbearing, to remove the ovaries and the tubes that are connected. That is really the most life-saving intervention that we can do for a woman who has inherited a BRCA1 or 2 mutation. There is also an increased risk of pancreatic cancer, and that's especially true for the individuals, both men and women, who have inherited a BRCA2 mutation. And these days, we actually do recommend screening for pancreatic cancer in BRCA2 mutation carriers and some BRCA1 carriers if they have a family history of pancreas cancer. Prostate cancer is increased in men, and it's the #1 cancer that men who have inherited a BRCA1 or 2 mutation are at risk for. And what's really particularly different for the BRCA2 mutation carriers, the men, is that the prostate cancer is very aggressive. This is not the typical prostate cancer that many men in the general population get. That's very slow growing and has led to some men really choosing not to screen for prostate cancer. For men with a BRCA2 mutation carrier, it's very aggressive and really needs to be screened for. And any abnormality in a PSA or in a rectal exam should lead to an MRI and a visit to a urologist right away. So this is a very aggressive form of prostate cancer. Individuals with a BRCA2 mutation also are at increased risk for a certain skin cancer, melanoma, and we recommend that they see a dermatologist annually just to look for any abnormal moles. So those are the cancers that somebody with a BRCA1 or 2 mutation is at risk for. Now, relevant to our talk tonight is that these inherited BRCA mutations are 10 times more common in the Ashkenazi Jewish population compared with individuals who are not Ashkenazi Jewish. Interestingly, not true for the Sephardic Jews. Their risk is the same as the general population. But for an Ashkenazi Jewish man or woman, if I knew nothing about their family history, 1 out of 40 will have inherited a mutation in BRCA1 or BRCA2. And that compares to the population that's not Ashkenazi Jewish, where it's 1 out of 400. I think this diagram says 1 out of 300, but in that ballpark. And this happens, this really enrichment for genes, both good and bad, happen when a population is sort of more genetically isolated. It can be isolation physically, and it can be isolation because of intermarrying over generations and generations and generations. And so these mutations are more common in the Ashkenazi Jewish population from Eastern European countries. So who should have genetic testing? Well, any Ashkenazi Jewish individual who has a family history of the 4 relevant BRCA cancers: breast cancer, ovarian cancer, pancreatic cancer, or an aggressive prostate cancer, a man where the prostate cancer has spread or he's passed away from it. Now, technically, we say a close relative, maybe a first or second degree relative, which means if you're Ashkenazi Jewish and either of your parents have one of these cancers, or your siblings, or your grandparents, or your aunts and uncles, your nieces and nephews, your children. And I would go so far as to say we even believe a third degree relative. So even if you're cousins, we generally know our cousins' health, And I would say if these cancers are in your family, please do talk with your healthcare providers about getting genetic testing. It can be life-saving. Now, some, and I have been one of these, have in the past really advocated that 1 in 40 is high enough that every Ashkenazi Jewish individual should have genetic testing for BRCA1 and 2. But it's not clear that insurance will always pay for that. They do follow some guidelines like NCCN, the National Comprehensive Cancer Network. And this is a little bit more in the gray area, whether if you have no known family history, but you're simply Ashkenazi Jewish, will insurance pay for it? And we'll talk a little bit more about the cost and what's involved. But this has been something that several of us in the genetic field have advocated for, because we also know that we don't always know what cancer our relatives had. Sometimes families don't share, if somebody had cancer. Some of us have particularly small families, and perhaps our father only had a brother and there weren't a lot of women. So I think this can be flawed to just rely on having family history. So again, it's something to talk about with your healthcare providers and to explore if you're interested in. So and for most individuals, certainly if you have the family history, there will be no cost, or it would be at most $250, depending. Now, why do genetic testing? Some people have said, why would I want to know that I'm at risk? And I'm a firm believer that I'm not advocating to know if you're at risk unless there's something we would do about it, unless there's something useful that one can do to lower that risk or prevent the cancer. And that's exactly what we are talking about. So we can identify that a man or a woman is at increased risk of these cancers, and we can screen for them. We can do more intensive screening. We can start younger. Sometimes there is preventative surgeries that will eliminate the risk. So there are a lot of options, and they're very effective, and we know that because we've been doing this for really almost 30 years. And so we know that this approach of identifying those at risk and screening and doing prevention strategies saves lives. And that's what the data say. It's saving lives. And it's not just for ourselves. Obviously, if we do genetic testing and we're found to have a BRCA1 or BRCA2 mutation, then that's relevant to our siblings. It's relevant to our children. It's relevant to our cousins and other relatives. So it's very important. There are also reproductive implications for the next generation, our children or our own generation, if we're young enough. For example, if an individual has a BRCA2 mutation, we said that they can pass it on to their children, and their children may have increased risk of cancer. But if an individual with a BRCA2 mutation marries or is having children with somebody else who has a BRCA2 mutation, that can be very serious for the fetus, for the child, because if a fetus inherits a BRCA2 mutation from both parents, then that can lead to a very serious illness called Fanconi's anemia. So I think sometimes knowledge is really power. I would urge everyone not to be afraid. And we're going to talk about, are there downsides of testing and things that people have heard. But I think it's really important to be proactive, to have the knowledge, to deal with the risks head on, and to really be able to do something like genetic testing in one's partner, because there are ways to mitigate or avoid some of these serious implications of, for example, two people with the gene producing a child. Now, what's the right age to do genetic testing? For some people listening, they're wondering maybe for their children. So we say that for those assigned female at birth, that genetic testing should happen either at age 25 or whenever that female is planning on starting a family, whichever comes first. So thinking of having children, that's a time to know if you have one of these gene mutations so your partner can test. There are also strategies these days that if you have the mutation, there are reproductive technologies available so that you don't pass it on to the next generation. And I won't go into too much detail about that, but they're really amazing techniques if one is interested, if a couple is interested. And we've been doing this for decades, and it's extremely effective. Now, for a male or someone assigned male at birth, and the reason it's 25 for the females is that's when we start screening for breast cancer. So you either start screening for breast cancer, or if you're going to start a family before age 25, you'd want to know if you have the gene. For males or assigned male at birth, it's really the prostate cancer screening that starts at age 40. And so either age 40 or when that male is thinking of starting a family, again, whichever comes first. So those would be the ages I would recommend it. Now, what about the risks? People have heard all kinds of things, you can be discriminated against and other things. So I'll start by saying that there is a federal law, GINA, the Genetic Information Non-Discrimination Act, that protects individuals from their genetic information being used against them for employment or health insurance, and it's really a very effective federal law. But many states, including Massachusetts, have even better state laws in place. So I will tell you, for all the years I've been doing this since 1997, when they really cloned and found BRCA1 and 2, and we've been clinically testing for it, I really don't know of somebody who has faced discrimination because of the genetic testing. Technically, there are some loopholes in GINA, for example, that are felt to be perhaps more luxury than necessity. They're not like health insurance or employment. So theoretically, there can be issues with getting life insurance or long-term disability insurance or long-term care insurance. And this is where genetic counselors will counsel those undergoing the testing to say, maybe you want to get some life insurance first and then we'll test. But I do want to be really clear that these theoretic issues are not a reason to not test. Because if you have one of these mutations, again, it can be life-saving to find out you have it and to proactively deal with the risks, like ovarian cancer. And if you don't have it, there's nothing to be worried about. There's nothing anybody could discriminate against. So I really, if one of the strongest messages is to not avoid the testing because of fear of these kind of issues, which honestly, in practicality, really don't exist in my experience very much. So how is it done? If somebody wants to proceed and they want to talk with their healthcare provider, it can be done through a blood test. But actually, since COVID in 2020, we've been doing most of the genetic testing remotely, and by counseling remotely and by sending individuals a kit, and they can just swab their own cheek and then mail the kit in, and then a genetic counselor would call them with the test results. So talk to your healthcare provider. All of the big hospitals and many community hospitals have their own genetic testing programs, and that's the way I think often to proceed. And these days, I've been focusing on BRCA1 and 2, but for those who do get genetic testing, it's rarely just those two genes anymore. Really, when one gets genetic testing, they get tested for a panel of many genes. It can be 14 genes, it can be 84 genes, and these are all genes that can inform somebody if they're at increased risk of not just breast and ovarian, but many, many cancers. And that's part of the counseling to figure out how large a panel you'd want to test for, or whether you'd want to be more focused based on the cancers in your family history. So let's say you do genetic testing and you don't have one of these BRCA mutations, or you don't really qualify for testing. How do we figure out what our risk of breast cancer is as women? Well, there are other risk factors, and perhaps the biggest one actually is age. 75% of breast cancer that happens in America is really in postmenopausal women. So it might seem counterintuitive because as we get older, we have less estrogen around. We go through menopause, and estrogen is such a culprit for developing breast cancer. But cancers are an accumulation of cells making mistakes, and that accumulation happens over decades and decades. So age is really one of the number one risk factors. We talked about family history. A lot of individuals have a family history of breast cancer. They do the genetic testing and we don't find anything. But that doesn't negate the family history, because there are probably lots and lots of genes we have yet to discover that can increase the risk of breast cancer. So family history of breast cancer is very, very important and does raise someone's risk of getting breast cancer, even if they have normal genetic testing. Having had a previous breast biopsy, even if it was benign, sometimes you get a biopsy and we see atypical cells in the breast, something called atypical hyperplasia or some other findings. So even a benign breast biopsy can give some indication that the breasts are tending in a direction that increases the risk of breast cancer. We're going to talk more about having dense breasts on mammogram. I know that's a very big issue for many women. So what's interesting, and I'm going to show you more in a few slides, if a woman goes for a mammogram and she has dense breasts, it's not only that it's harder to find a cancer because the mammogram is just not as sensitive at seeing the cancer, it actually means that she's at increased risk of breast cancer. So that is actually a risk factor, not just something that makes the mammogram less able to find cancer. And if somebody had radiation as a child, sometimes to their thyroid, sometimes to their chest, if they had certain cancers like Hodgkin's, that is another big risk factor. Anybody who had radiation before the age of 30, that really increases the risk of breast cancer. So let's talk about those dense breasts because it's such a popular topic. So if you look at this picture, on the left is what I would call a fatty breast. You can see it's pretty gray. And when you look on the right, it's very white. That's a very dense breast. And this has nothing to do with the way the breasts feel or their appearance. This is all how they look on a mammogram. And so fat is translucent, and that's why this looks gray. But the cells of the breast, the purpose of the breast really is to nurse, to have milk globules and then a branching network of ducts that bring that milk to the nipple. And so if you have a lot of cells along those lobules and ducts, that appears very white. That's opaque. So this is a dense breast. This is a fatty breast. Now the problem is a mammogram is looking for cancer, and cancer is white. It's either a white nodule or it's white calcifications. So it would be very, very hard to see cancer in a breast on a mammogram that looks like this, much easier in a breast like this. So again, one of the big problems with dense breasts are that it's harder to see the cancer, to detect it. But another issue is that the risk is actually higher. A woman who has the densest breast has a 5 times higher risk of getting breast cancer than someone who has the fattiest breast. And if we look at somebody who has the average density right in the middle, having the densest breast probably doubles your risk. So this is really a twofold issue, increasing your risk of breast cancer and making it harder to find the breast cancer. And if we look at another way, when you get your mammogram letter or your report, there is a scoring system for density. It's a BI-RADS scoring system. And there are letters A, B, C, D, and it's easy to remember because D is for dense. So A, B, C, D, A would be the least dense and D would be the most dense. A lot of times on the mammogram report, you won't see this. What you'll see are words, And here are the words that are equivalent to those scoring systems. So if the report says that the breast is heterogeneously dense, that's a C. If they say they're just scattered fibroglandular tissue, that's a B. If they say it's extremely dense, making it very hard to see anything, you know you're talking about D. And what's interesting is about 50% of women, therefore, have dense breasts. Now, I'm a breast cancer medical oncologist. A lot of times women come in thinking they have dense breasts because the report will say they have scattered fibroglandular densities. They see that word dense, but really they're here at B and they're not having dense breasts. Now, one of the problems with this whole scoring system is that it's not automated. It's not even quantified. And so there's a lot of there's a lack of reproducibility from one mammographer to the next sometimes, or even they've done studies if the same mammographer is reading a woman's mammogram year after year, and they don't know they're reading the year before. Since 80% of women live in the middle here between B and C, one radiologist might call it B and one might call it C. So it's really quite an imperfect system. But if you clearly are sitting here in this more dense area, it is a higher risk and harder to find the cancer. So there are various models that the physicians and clinicians use to combine all the risk factors: family history, age, whether you've had a previous breast biopsy, your reproductive, when you started menstruating, how many kids did you have, all of that. I forgot on the slide to put reproductive factors. And all of those risk factors, density of your mammogram, are put into these models, and they provide a lifetime risk that woman has for developing breast cancer by age 80. And it also usually gives a short-term risk, what her risk is over the next 5 to 10 years. And the way we tend to think about this right now is that if somebody has a 15% or lower risk over their lifetime of getting breast cancer, that's considered pretty average. If they're over 20 to 30%, then we think of that as getting high, particularly over 30%. And if you're in that middle range, the 15 to 20%, then that's what's considered moderate. And these have implications for what we do for screening and other things. So keeping that in mind, the over 20% is sort of being high. Let's talk a little bit about mammograms and mammogram screening. And this is definitely one of my favorite cartoons. Yes, I did have my mammogram today. Why do you ask? And so what are the guidelines? What do they say? Well, it depends on which professional society you listen to. Are we listening to the American Cancer Society? Are we listening to the U.S. Preventive Services Task Force? That's more for primary care doctors. Are we looking to the American Radiology Society or the Gynecologic Oncology Society? They all have different guidelines. But in general, for the woman with average risk, and that's really important, average risk, they say that women should start their mammograms around age 40 to 45 and to do the mammogram annually. And then if they reach maybe 55 and they really still have no family history or no other major risk factors, they can talk with their doctor and maybe they can consider doing it every other year, although they all still allowed to do it every year if a woman prefers. So it's really, listen, I'm a cancer doctor. More is better. I'd love every woman to start at 40 and do it annually. But I think this is some discussion with your primary care doctor, your healthcare providers, your gynecologist to talk about it. But certainly I think most women should be starting at age 40 to 45 and starting at least for the first 10 years doing it annually. Now that's for women at average risk. And one other point I wanted to make, women always ask about 3D mammograms and 2D mammograms. So a 3D mammogram is really what it sounds like. It takes more views and has a three-dimensional picture rather than a 2D, just two views. A 3D mammogram is called a tomosynthesis. And I would have to say that almost any everybody today is getting a 3D mammogram. I think there are very few still doing 2D mammograms. A 3D mammogram is not tremendously better at finding cancer than a 2D mammogram. It's really not a home run. It's actually, out of 1,000 women who go to get their mammograms, you might find one more cancer. So it's not tremendous, but it's a little bit better. What it is better at is avoiding some of the false alarms. Some women will get a letter that they have to come back for more views. And a lot of time that's because the breast was just folded over on itself. And if you only have 2 views, you can't really tell. But the 3D mammo, the tomosynthesis, will avoid a lot of that. So, and that's a lot of anxiety in getting that letter and having to come back. So I think 3D should be our very minimum. That should be our basic mammogram. Now, what are the guidelines for women who are at increased risk? So this is not average risk. This is increased risk. And if you have a greater than 15% lifetime risk, you should start your mammograms no later than age 40. That really should be the very latest. But in your family, let's say you did your testing, you don't have a BRCA gene, but you had an aunt who had breast cancer at 40, and don't wait till 40. We generally always say you should start your mammograms 5 to 10 years younger than the youngest woman with breast cancer in the family. So that's a good rule of thumb. So if you know about your cousins and your aunts and uncles, if there's somebody who had younger breast cancer, you should start 5 to 10 years younger. And that's a general rule of thumb. Now, what if your risk is really starting to get up there? What if your clinician, your healthcare provider, has calculated that you really do have a greater than 20% lifetime risk of breast cancer by age 80? That's where a breast MRI comes into play. And this is just a picture of how it is. It's more involved than a mammogram. Women lie on their stomach, their breasts hang down through this table, and they're sort of put into this machine that's a little bit tighter than a CAT scan, if you've ever had a CAT scan. Breast MRI is the gold standard for finding breast cancer. It finds breast cancer when they are tiny, tiny, so much earlier than a mammogram could ever find most breast cancers. So for women who are at increased risk, we recommend they have an annual breast MRI. In addition, it doesn't take the place of the annual mammogram. They're actually complementary, and the mammogram may still find some precancers, calcifications, even better than an MRI. So you want to do both, and you want to space them apart 6 months. And that's what we do, certainly for our BRCA mutation carriers, but anybody who's got a significant family history and that risk starts to get up there. Now, somebody might say, if the breast MRI is so much better, why aren't we doing this in everybody than a mammogram? And the problem is that it really wouldn't be feasible. And that's why we reserve it for women who really are at increased risk. First of all, it is a little claustrophobic, although most women can deal with it just fine. Some women do need, a little bit of a sedative beforehand and have a friend drive them, but most women do just fine. If you do have kidney issues, then you can't have the contrast, the gadolinium that is needed to go with the MRI. So there is an IV and some contrast that's given with this test. It's not interpretable without that IV, and you need healthy kidneys for that. But the biggest issue is really the false alarms, the false positives. When you have a test that is so exquisitely sensitive, that sees everything, it sees a cancer when it's teeny tiny starting, it's going to see a lot of things that it doesn't know how to interpret. And so there can be false alarms, callbacks, and even unnecessary biopsies. And that's why you wouldn't want to do this for everybody, women who are at lower risk or average risk. You really want to reserve this for women who at least have that greater than 20% lifetime risk. There's also a cost to our society and our healthcare system. So I think, again, just like anything else, you want your personalized treatment for a disease or cancer. You also want your personalized risk strategy. You want to know what your risk is. And for women who are at higher risk, we want to do more. And for women who are at lower risk, we can do less appropriately. Now, what about a woman who can't get a breast MRI for some of those reasons, but needs one? Or somebody who has dense breasts, but doesn't quite make that over 20%. Some of the things that are really being looked at, and the Beth Israel was one of the pioneers, and I know Memorial Sloan Kettering has done a lot of research in this, is something called a contrast mammogram. And this is for the patient, feels exactly like a regular mammogram, although she does get an IV placed. And so there's the same kind of contrast you would get with a CAT scan. And, you know, there's, instead of taking 2 or 3 views, a machine arcs over the breast and maybe takes 15 pictures of the breast and then reconstructs it. And you basically get a very detailed image of the breast with contrast. So here is a regular mammogram, very dense breasts. How could you ever see a cancer in here? And here's a contrast enhanced mammogram that shows the cancer there. So I think contrast mammogram is something that is being used more. Unfortunately, these days it's not quite reimbursed as it should be. But I think that for somebody who doesn't quite meet needing an MRI, has dense breasts, or really qualifies for an MRI but can't get it for various reasons, we definitely advocate for contrast enhanced mammograms. A lot of people ask about ultrasounds. You know, ultrasounds really are not great for screening. Certainly nothing like an MRI and nothing even as good as a contrast mammogram. It's simple and it's done right at kind of the bedside in the radiology suite. It's really better if you know where you're looking. So if a mammogram shows an abnormality and you know where to zero in, that's great to use an ultrasound. If a woman feels a lump and you know exactly where you want to zero in, that's where to use an ultrasound. But to do ultrasound, just sweeping the breast, trying to screen for more cancers, the studies show it doesn't really pick up that many more cancers, and it also has a lot of false alarms. And so it kind of is not really used for that. I know that there are always women who come in saying, but that's how mine was found. You know, I was screened with an ultrasound. But in general, that's not something. There are places that for women who have dense breasts, they will do a regular mammogram and an ultrasound. But I think more than not, institutions tend not to be happy with using ultrasounds in that way. So if you are at increased risk of breast cancer, is there anything in your power that you can do, not just to find a cancer early, not just to screen for it, but to actually lower your risk? Well, there are some lifestyle strategies that absolutely reproducibly decrease the risk of getting breast cancer. So these are hard things to do sometimes, but maintaining optimal weight, we know that weight loss at any age decreases the risk of breast cancer. We know that doing exercise that gets your heart rate up decreases the risk of breast cancer. 3 to 4 times a week, 20 minutes or more, really can take, you know, a fifth of the risk away for somebody. So very, very effective. And limiting alcohol. Alcohol actually increases our estrogen levels, and breast cancer is very much an estrogen story. It is the accumulation of decades and decades of estrogen feeding our breast tissue, and that the breast cells make mistakes, and that's how cancer happens. Alcohol raises those estrogen levels. So we don't say zero, but we certainly say not to drink every day and to try to keep it, especially if you have a family history, if you have some other risk factors, try to keep it to 3 or 4 a week or less. And those are healthy things one can do. There are medications. People may have heard about tamoxifen or aromatase inhibitors or raloxifene. There are medications, some of which we use to treat breast cancer, that have been studied in very large trials of thousands of women that have been shown to lower the risk of breast cancer. But of course, medications can have side effects, but this is part of the whole risk assessment and prevention strategy that programs do. We assess the risk and then we discuss with women and patients what are the appropriate strategies, both for screening and prevention. And for many women, taking a prevention medication does make sense. So that's something you can ask your physician about. And finally, at my last slide, a lot of people ask about birth control pills. They may have a family history of breast cancer. Now their daughter is of that age and starting to take birth control pills. And is that safe? Does it raise the risk of breast cancer? Well, any hormonal contraceptive strategy, whether it's an oral contraceptive pill, whether it's a hormonal IUD like a Mirena, whether it's a patch or an injection, or any hormonal contraception does modestly increase the risk of breast cancer. And they're all about the same. Unfortunately, however, if a woman has not completed childbearing, there aren't that many highly effective contraceptive strategies. There is a non-hormonal IUD, the copper IUDs, but I know a lot of women don't like them because can be abnormal spotting and bleeding with those. But it is an issue. After childbearing is complete, of course, a couple can discuss whether it's tubal ligation or vasectomy. There are other ways of a contraception, but I think this is something we just have. I mean, there are barrier methods, but I think they're just not felt to be highly, highly effective. So I think we just sort of accept that there may be this modest increase. I think avoiding an unwanted pregnancy is, of course, a very, very important goal for many women. And so I think we just sort of say that women should choose the contraception that makes the most sense for them and just think about other ways to modify the risk and to not worry terribly much about that. And I think I'll conclude there.
Thank you so much, Dr. Tung. I actually have a few questions, and
Absolutely.
don't mind. Your slide about if you're Ashkenazi Jewish and cancer runs in your family, when to test. What if you're not Ashkenazi? What if that is not your background? Are the recommendations the same?
Yes. So if you, so let me try to say it this way. The threshold, the bar for testing is lower if you're Ashkenazi Jewish. But most individuals in this world who have a BRCA1 or 2 mutation are not Ashkenazi Jewish. So many, many non-Ashkenazi individuals have BRCA mutations and test. So if you are not Ashkenazi and you have a family history of breast, ovarian, pancreas, prostate, you also should talk to your clinicians about doing testing, and the ages would be the same. 25 or younger if you're a woman, and 40 or younger, 40 or when you're thinking of starting a family if you're a man. So I think the only difference is that if you're Ashkenazi Jewish, really the big difference is, I think, the discussion about whether if you have no family history, if you should test. That's really the difference. But I think for Sephardic Jews, for non-Jewish individuals, those family histories should lead somebody to have a conversation about doing the testing.
That makes sense. And I know this is a big question, but when would someone consider an elective mastectomy or having their ovaries removed?
Yeah, so that's a very, very personal decision. Certainly for our, let me go back to the slide about, the risks. So, certainly for our BRCA1 and 2 mutation carriers, whoops, when we have, let's see if I can do it this way, whoops. Okay, well, at the top there, the greater than 60% lifetime risk of breast cancer, many, many BRCA mutation carriers do think about having preventative mastectomies. They don't want a life of doing mammograms and MRIs and false positives and biopsies. Other women say screening is great, and they sail through it and don't have a problem. So I think that's a very personal choice. I mentioned that there are other genes. It's not just BRCA1 and 2. There's one called PALB2, which many people think about like BRCA3. Many PALB2 mutation carriers think about preventative mastectomies. I think it's a decision that a woman will have. The first step is, what is my risk of breast cancer? If the risk is 20%, most women are not going to be doing preventative mastectomies for that. But if the risk is 50 or 60 or 70%, then it becomes a discussion. Very personal choice. I want to really emphasize that what has changed it to allow women to have a choice is that these breast MRIs are so incredibly sensitive, and they find breast cancer usually when it's very small, very treatable, and usually very curable for women who are doing the screening faithfully. Before we had that, if we only had a mammogram, it wouldn't be sufficient, and we'd be recommending preventative mastectomies to all the women who have a really high risk of breast cancer. But I think a lot of women do overestimate their risk. Maybe their mother had breast cancer, but when they actually get the number, all of the risk factors are put into the model, sometimes it's lower than women really expected, and that should be some reassurance not to stop doing their screening, but I think would make them feel more comfortable about the screening strategy that they're doing. So I would say it's in consultation. I will also say that for those whose risk is high enough, and I just counseled somebody last week who didn't have any genetic mutation we could find, but there was so much breast cancer in her family, almost every woman, that's what she opted for. And the good news about that is that the preventative surgeries and the cosmetic reconstructions that are available now are remarkable. There are nipple sparing, mastectomies where the entire outside of the breast is maintained, and just the breast tissue is removed and either replaced with an implant or tissue from somewhere else in the body. So very often when the scars heal, it's really impossible to tell physically that one has had that done. So I think there are more options than we've ever had, both for screening, but for preventative surgeries. And I think it all starts with a careful evaluation of the family history and that individual's risk of actually developing cancer.
Thank you. And then just my final question, what type of doctor would order genetic testing? Would it be a primary care physician, OBGYN?
That's a great question. It's typically a primary care doctor or a gynecologist, just as you said. Now, some will actually order their own genetic testing, and only if it comes back abnormal, refer someone to a genetic counselor, because there is limited resources, limited number of genetic counselors. Others are affiliated with hospitals and would just refer their patients to the genetic testing program at that hospital and let the genetic counselors take it from the beginning. So I think either way, the most important thing is to get the test, but then speak to a genetic expert if there's anything on that sheet that isn't 100% normal, because I think that genetics are complicated. And I think a lot of times people criticize too much genetic testing in these big panels with many genes because they're afraid that the results will be misinterpreted and too much will be done, or people will overreact or do too much. And I think that's a legitimate concern. But I think at least here, Newton, Boston, this area, it's really just such a mecca of so many really experts in genetics. So it's not hard to take your results and find a genetic expert who can really help you think through it and what's appropriate for you.
Thank you. Well, thank you, Dr. Tung, and special thanks to Beth Israel Deaconess Needham and Beth Israel Deaconess Medical Center for sharing this important information about breast cancer screening and genetic testing. If you would like to hear this presentation again, or if you know someone who might benefit, we will be posting the recording on the JCC Greater Boston website on the Wellness Speaker Series. If you have any questions about JCC Greater Boston's programs, we have lots of exercise classes. You can also email me. My email is hwhite@jccgb.org. Thank you so much.
All right. Thank you so much, Heidi. Bye-bye.